Good evening. I hope you're all keeping safe and well. I'm Anna Sargent, Medical Affairs Manager in Paediatrics at Nutricia, and I'm delighted to welcome you to our webinar this evening and to introduce Dr. Luise Marino, Amber Green, Brittany Rothman, and Catherine Kidd, who are going to be speaking on what's next for improving nutrition and growth outcomes in infants with congenital heart disease. Luise is a clinical academic paediatric dietitian in cardiology and pediatric and neonatal intensive care at Southampton Children's Hospital, and also senior lecturer and program lead for nutrition and dietetics at Winchester University. Amber, Brittany, and Catherine are paediatric dietitians, all based at Great Ormond Street Hospital for Children in London. Amber and Catherine are both highly specialised paediatric dietitians working in cardiology and intensive care, and Brittany is a paediatric dietitian working in cardiology at present. The presentation will last approximately 45 minutes, followed by 10 to 15 minutes for the live panel discussion, where your questions will be answered. Please do send in your questions via the Q&A box throughout the presentation. We will endeavour to answer as many questions as possible. Thank you, and over to our speakers.
Thanks, Anna, for that introduction. I'd like to thank Nutricia for the opportunity to participate in this webinar. And today we're going to be thinking about what's next for improving nutritional and growth outcomes in infants with congenital heart disease. I have no financial disclosures relationships to disclose, and these are some of the learning objectives. So today we're going to be describing the importance of optimised nutrition in infants with congenital heart disease, and we're going to understand the role of nutrition management. So in terms of background, congenital heart disease is the largest single group of congenital abnormalities. There is a prevalence of 8 to 10 per 1,000 live births, and that equates to around 4,000 infants in England per year that require surgical intervention. For surgery to happen, an optimal weight needs to be achieved, and poor growth jeopardises surgery and good outcomes, and really increases parental anxiety. So just to give you some context, there are 10 surgical centres for paediatric heart surgery in England, 3 of which are in London, and the rest are spread out across the country. And as you can see from this picture and this graphical representation, there is large geographic spread between centres. So many of the infants that we see within our surgical centres have never probably seen a dietitian prior to them having surgery. So the risk of growth failure in these infants is quite high, which is why trying to implement a nutrition pathway to reduce variation in practice is really important. So a few years ago, we did some work at Southampton looking at the prevalence of malnutrition amongst our regional cohort, and we found that we had 28% of our infants had persistent malnutrition, so -2 Z scores. Those who were underweight at the time of surgery spent 9 days longer in hospital, and there was a significant increased risk of dying at 12 months of age. And what's important about these findings is that they're irrespective of the cardiac lesion or the severity of surgical score at the time of operation. So this suggests that nutrition is an important outcome of morbidity and mortality. Work by Kate Brown has also shown amongst a large cohort of infants having surgery, there are 9 early morbidities following cardiac surgery, and this affects 22% of infants have at least one, and feeding is the most common problem. This is important because up to 30% of infants have a feeding difficulties before surgery, and post-surgery 6% have a new feeding issue. So that's up to almost 40% of infants have a feeding problem. And this increases their hospital length of stay. So in terms of growth, I think it's really important to think about growth, velocity, and how it may be disrupted due to medical, non-medical causes or a combination of both. And I think it's important to think about growth in terms of whether it's influenced by reduced or restricted intake, so whether that's medical restriction or restricted intake because the infant can't take more. There's excessive losses, so the most common thing that we see is vomiting, and or there are increased requirements, so particularly in infants who have a left to right shunt, so something like a ventricular septal defect. And all of these contribute to impacting on growth. So sometimes we see infants being admitted to for surgery who've been put on either an amino acid infant formula because they've got suspected cow's milk protein allergy. And for many of these infants, some of them do have cow's milk protein allergy, but most of them don't. And most of them have feeding difficulties and gastrointestinal disturbance because they've got heart failure. So CHD results in gastric emptying that's slower, particularly in the first hour. They often have anorexia, so they've got small meal volumes, they've got early satiety. They've often got feeding disorders due to foregut dysmotility. They often have esophagitis or GORD, and often they have midgut dysmotility, and that results in abdominal pain. So many of these infants have a really poor feeding experience. So this is some work that we did a couple of years ago, and we just wanted to check the impact of infants being on an amino acid infant formula on weight for age Z scores. And normally when you change an infant to an amino acid infant formula for proven cow's milk allergy, they tend to grow better. And in this cohort of infants, we didn't see the same. So as with standard infant formula, changing infants over to an amino acid infant formula may not support adequate growth. So why might this be? So there are many factors that impact on growth, and many growth factors that are associated with that. So there's nitrogen, potassium, sodium, magnesium, zinc and phosphorus. So if you've got an inadequate supply of any of these, growth will be poor. So if we think about some of the medical contributors to that, we often use diuretics. So they result in increased losses of potassium, sodium, magnesium and zinc in the urine. And then we often many of these infants are on PPI, so that impacts on their ability to absorb phosphorus. So all of this contributes to poorer growth. So what have we been trying to do about it from a BDA Paediatric Cardiology group? We've been working on the development of a nutrition pathway. So before PICU, we've tried to promote growth. So we've developed some paediatric, some parental feeding information. We've tried to normalize feeding patterns. During PICU, we've tried to reduce deficits. And then after PICU, we've tried to promote catch-up growth and overcome feeding difficulties. And importantly, this has input from a multidisciplinary team. So trying to reduce the deficits during the PICU stay, we routinely use a nutrient energy dense peptide feed. And what this does for us is we are more able to meet nutritional requirements very early on. So particularly within the first 1 to 5 days, we start using the formula at full strength from day one, and we've had very good results. And this study was just a 2-center study looking at cohorts that spent more than 14 days in PICU with us and Erasmus in the Netherlands. So a couple of years ago now, we worked with the paediatric group, and we published a Delphi consensus developing a nutritional pathway to improve growth in infants before surgery. And really the aim of this was just to think about how we could organise our care better and how we could reduce variation in practice. So really it just takes you through some principles about thinking about the impact of the cardiac lesion may have on nutritional status, and also what, how and when the infant drinks. And you may advise this to either increase the amount of nutrient energy dense feed, so to perhaps a 50-50 proportion, and or they may need 100% of a nutrient energy dense feed, and they may need more regular follow-up. So guideline implementation is always a tricky thing, and there are many barriers and enablers to this. So for guidelines to be implemented, people need to believe them, they need to feel that they're credible, they're feasible, and they're accessible. So these papers that we've developed and published are all open access, and they're freely downloadable, and we're always willing to share our information. It also needs that individual professionals have awareness of the guidelines. They have, and they feel that they have sufficient skills and self-efficacy to be able to implement them. And there's also the social context, so the opinions of colleagues and the social pressure within an organisation. Importantly, there's organisational context. We were lucky to be able to get additional resource to be able to implement the guidelines, and there's time associated with the use of guidelines. And then there's the team process and the care process, thinking about the referral and the support of staff. So looking at what the guideline implementation has done for infants within our regional service. So we've following the implementation of the guidelines, we've shown that there's a significant improvement of weight at the time of surgery and at 12 months of age. And importantly, we've also been able to significantly impact on their length for age at 12 months of age. So that means that all of their organs are growing. From a clinical outcome perspective, we've also managed to reduce PICU length of stay by 10 days and mechanical ventilation by 10 days compared to a historic control. So typically we would have an infant with a severe cardiac lesion, and we wouldn't wait for them to fail to thrive. We would intervene early, and we would do a combination of breast milk and energy and nutrient dense infant formula. So as you can see from this growth chart, this child has managed to keep growing along their length centiles and weight centiles. We introduced energy and nutrient dense complementary food at around 20 weeks of age. And once the child had had surgery, the growth was so good, we were able to switch back to a standard infant formula. We've also developed some parental information, some recipe books, and again, we're always happy to share these. So during the COVID pandemic, we've done some research about the impact this has had on families of CHD and children, and we really wanted to understand the experience and information and support needs of these vulnerable families. So unsurprisingly, parents felt that there was a significant concern about the virus. They wanted more information from the clinical team, and they wanted information that was specific to their child's heart disease. They felt that the hospitals were no longer a safe place, and this was particularly during the first national lockdown, and 84% had planned surgeries or appointments cancelled. So lockdown and isolation was a significant theme, and 50% of parents shielded their children despite not having an official letter. So what does this mean for parents of infants with CHD and dietetics? So as part of our implementation pathway, we developed a telephone service. So Leanne and Claire, who were part of the team at the time, were able to phone parents on a more regular basis. So the COVID pandemic for us and through this research we've been able to see has really affected the mental health of parents. It's made them feel vulnerable. They've got a heightened level of stress. They've got uncertain financial circumstances, closure of schools, delays in medical treatment, and families have felt forgotten and abandoned. So really, we've had been a role of advocates in listening to parents during this difficult time. So in summary, the use of a nutrition pathway preoperatively can improve growth and clinical outcomes. Feeding difficulties are very common, and they may be related to delayed gastric emptying and not a food allergy. Growth failure occurs early within the first 4 to 6 weeks of life. It's very difficult to achieve catch-up growth before surgery once growth failure has occurred, and it's really important to prevent growth failure in the first place by intervening early using a combination of breast milk, standard infant formula, and nutrient and an energy-dense feed. So in terms of future research, we really need to think as a group of clinicians how we can reduce variation in practice and how we can support the implementation of evidence-based guidelines nationally. We need to think about developing post-operative pathways to support infants and children, particularly those with new feeding difficulties. We need to think about how oral feeding early in life improves feeding outcomes, and we need to better understand the parent journeys in feeding their children. And finally, we really need to work towards personalised nutrition to improve growth and long-term outcomes, including reducing the risk of obesity in children with CHD. And I'd just like to thank my supervisors and mentors and collaborators, including Catherine Kidd, Natalie Davis, Julie Feinberg, Leanne Rees, Claire Riches, and Carolyn Johnson, who are all dietitians who participated in this important research. And now I'd like to hand over to Brittany, who's a specialist dietitian at Great Ormond Street, working in the Cardiology service. Thank you very much.
So thank you so much to Luise for handing over, and thank you so much to the Nutrition team for allowing us to present today. My name is Brittany. I'm one of the rotational dietitians at GOSH, and today I'm here to present a survey which I conducted towards the end of last year, and it's about what the current cardiac services are available in the community. Just looking into what we wanted to achieve with the survey, we wanted to determine what current outpatient dietetic services were available, what the awareness is of the Delphi guidelines and the confidence in the use of the Delphi guidelines, which cardiac infants require further support from tertiary centres, and the use of the above to further develop our GOSH outpatient service and to liaise with local services. Just looking into our method and results, we conducted our survey using an anonymous survey monkey, throughout the period of August to October 2020 with various different NHS trusts and dietitians that we frequently liaise with and who we frequently discharge to. And we conducted using the platform as well as telephone calls and reminder emails in order to increase our response rate. And how we wanted to distribute our service or survey was we used various platforms such as Facebook and Twitter, and we used various nutrition specialist groups in order to distribute. And just looking at the table on the right-hand side, it gives us a good idea of the distribution of how we attempted to get in touch with various locals, and these are the areas which were listed. Then just looking into our data collection, we achieved a 67% response rate, and a large number of our respondents, being 96%, were working within the area of pediatrics, and the 4% remaining would cover services such as adults. And then just looking closely into this work setting, 78% were working within the community, 13% were working in the acute care setting, and the remainder 9% were working in both areas. Looking into this further, you'll see that these answers don't add up to 100%, but it was just to get a breakdown of where our respondents' services were currently being offered and what their services were covering. So majority of our respondents, being 94%, covered home enteral feeding. The 81% covered outpatient service, 77% covered general pediatric services, and 49% covered inpatient services. We then wanted to know from respondents what would prevent them from taking a cardiac outpatient on their caseload, or what might prevent their team from accepting these patients. And through thematic analysis, the main exclusion criteria that were listed were the level of experience of staff, no growth filtering present, the short-term use of tube feeds, fluid restrictions, frequent input from hospital teams, overnight tube feeding, high-risk diagnosis, and specialist diagnosis. We then wanted to know what common cardiac diagnosis was seen in the community. The table above, in the top half of the screen, shows all the high-risk categories under the Delphi guidelines. The table below showed the answers from locals about what the commonmost cardiac conditions were that were seen. And you'll see from the highlighted versions, these are listed in the high-risk diagnosis. So what was seen was VSDs, ASDs, TOFs, HLA-EPs, and PDAs. Then just looking further into this, we wanted to know from local teams what was the waiting list for their team caseloads. And obviously this might be greatly impacted, as Luise had mentioned earlier, due to COVID. And lots of teams were redeployed, and of course, services might have changed. So these stats do require further investigation. But just looking into what we had as a snapshot, the average waiting times for these patients seen in the community were 36% being 0 to 1 month, 26% being 1 to 3 months, 6% being 3 to 6 months, 2% being 6 to 9%, and other listed as 30%. So you can see a large percentage did note other, and the teams had noted that patients could be seen within a 1 to 2 weeks of discharge. And they noted that it would depend on the following criteria if they were seen sooner. So for example, if they were urgent referrals, if they were under the age of 1 year old, but this was not listed for all teams, home enterally fed patients, and if they were deemed non-urgent, then they might be seen within 6 to 18 weeks. The data above is really important as it ultimately impacts this already nutritionally vulnerable group. Then just looking into the frequency of review. Again, these statistics require further investigation as the current climate might have greatly affected the outcome of this. But as Luise previously mentioned in her slides with regards to the Delphi guidelines, those patients falling under category B under the Delphi guidelines would be reviewed every 2 weeks. Patients that were under category C would be seen weekly. And then when asked how often these patients were being reviewed or seen within services, 69% of our respondents noted other, 9% reported every 3 months, 8% reported monthly, and 8% reported bi-monthly, and 6% reported weekly. The result which jumps out the most from this collection of data was, for example, that those that didn't indicate other, noted being 14%, were unable to meet the criteria of the guidelines to review patients weekly or bi-weekly. And this just shows us the additional support which is needed by local teams and that we need to communicate effectively between one another. Then just looking into the awareness of the guidelines and the confidence in the use of the guidelines. This was one of our aims. And so the Delphi Consensus Guidelines were published in April 2018, and they were disseminated in a number of ways, being providing copies of guidelines to pediatric groups. It was endorsed by the BDA. There were completed editorials. There were study day presentations, and they were included in the Clinical Pediatric Dietetics as well as the Dietetic Pocket Guide. And then just looking at the awareness of these guidelines, it showed that majority, 57%, were not aware of the guidelines, and 43% are aware of the guidelines. The next question was the overall confidence in the use of these guidelines, noting that 19% were very confident, 52% somewhat confident, 15% not so confident, and 4% of the participants were not at all confident. And just to sum this up, 71% indicated they were not or somewhat confident in the use of the guidelines, and 29% being very confident in the use of the guidelines. So it's very important for us to distribute this effectively and know what the capabilities are of our colleagues. Just looking at our current barriers for reviewing our patients. So again, this was one of our questions, and we really wanted to know what we could do and where we could improve. So 56% noted lack of MDT input. For many dietitians working in isolation, they find it very difficult to access specialist information, and it's therefore really important for us to determine where we can aid teams. 40% noted fluid restrictions, where teams struggle to get updated guidelines for this. 40% noted time restrictions, as we've previously mentioned. 34% unable to manage the regularity of the reviews, and 30% indicated other. And this just commonly echoed the themes which have already been mentioned on the slide. And 20% noted conflicting guidelines, and 18% noted unknown guidelines. Just looking at what we could do for input for tertiary centres, from the above data, as we wanted to know where we could help. So 56% noted from the majority of our respondents indicate that they did not feel that GOSH would need input with their patients, and 44% noted that they did require input for their patients. So just looking into this a little bit further, we wanted to know where and what cardiac conditions we need further input for. So these are the listed reasons which dietitians wanted us to be involved with. And just to echo a few of these is that patients require more frequent input, as we've seen from the previous data, and specialist diagnosis, as well as the high-risk diagnosis being your single ventricle pathway patients and your complex cardiac conditions. Then we wanted to know how we could further develop our outpatient service, and these were the most commonly answered questions, or the most commonly answered suggestions for us as a team. So the provision of study days and webinars, the provision of a discharge pack, which would include all of the below, and effective communication between us and local teams. Then just looking at the next slide, these were the most frequently asked questions from our colleagues. And so these questions will be addressed by my colleagues' case studies by Amber and Catherine. And just looking into what we will be looking into, we'll look into anthropometry, biochemistry, clinical questions, dietary questions, and environmental.
Hello, my name's Catherine and I'm one of the cardiac and CICU dietitians at Great Ormond Street Hospital. Thank you, Louise and Brittany, for both of your incredibly interesting presentations. I've learned a lot and I'm sure other listeners will have as well. I was going to present a case study of a single ventricle infant. Now, this little girl was born at term with a diagnosis for hypoplastic left heart syndrome. And these children undergo 3-stage palliative surgery. So the first operation is called the Norwood, or often known as the stage 1, which is normally within the first week or so. The Glen, which is stage 2, between 4 and 6 months. And the TCPC, which is stage 3, which is between 2 and 4 years. So just talking about general principles for managing single ventricle patients. And really I've chosen this case study because of quite a few respondents to Brittany's fabulous survey said that they struggled managing these patients. So I just thought we'd go through a few general principles first, and then we'd look at what we did for this particular patient. So when you're thinking about anthropometry, our expectations for growth for these infants are actually in line with that of healthy infants, but there's a very high rate of stunting. It's really important when you're looking at cardiac infants to be measuring their length as well as their weight. And that's because length is a very good indicator of long-term nutrition. It's very important to record their birth weight, length and head circumference because this will guide catch-up growth. Now, sometimes at Great Ormond Street, we actually really struggle with this because we don't have a birthing centre. So all of our infants are born in their local hospitals and transferred here. So we're relying on transfer documentation. Often it's our information can be a bit holy, and you'll see that when I get to my next slide for this little girl. Growth faltering post-Norwood is really high, and that's because often they're feeding pre-Norwood and shortly post-op is very disrupted, and this can result in a longer hospital and intensive care length of stay. There's a study looking at duration of PN and diuretic dosage at discharge, and what they found is that a shorter duration of PN and a higher diuretic dosage, results in a lower weight for HZ score at discharge. We also look at biochemistry. So urine sodium can be low in long-term electrolyte use patients, which Amber will, I think, elaborate further on in her case study. But that can be really important to look at. However, it can be very difficult to interpret as diuretic usage can result in excess sodium loss. We may also be able to be checking their PN bloods as well. So this will differ slightly depending on which centre they're at as to when PN is initiated. Different centres will have different guidelines for this, and also when PN bloods will be done. This is done when the CRP is in range because that can affect micronutrient status. But also some centres do it when PN is initiated, whereas other centres do it for children who are a longer term PN. So if they're available, then it's something to interpret, but it won't necessarily be a blanket for infants. When it comes to clinical information, the fragile interstage infants, and by that I mean infants between Norwood and Glen, have shunt-dependent circulation. So their systemic circulation is dependent on a shunt, which is sometimes referred to as a duct, and their fluid requirements is similar to being in line with non-cardiac infants. So 150 ml per kilo is used as our ballpark. That isn't a blanket for all infants, but it is very often used as a target. So this is much more liberal than many other cardiac infants. And fluid intake could be a combination of oral, enteral and intravenous fluids. Dietary information. Sometimes TPN is initiated at birth. This is dependent upon local guidelines. So at Great Ormond Street, we don't feed our pre-Norwood babies. And when we initiate feeding after Norwood, this is done on the high-risk abdomen feeding protocol and is in advance slowly. So it can take them a while to reach full enteral feeds. Oral feeding should be first line for these infants, but many infants do require a nasogastric tube. We use the Delphi guidelines to guide our nutritional aims. And these patients, because they have a high-risk diagnosis, will be care plans B or C. We always think about vitamin D. Often, many unwell children have a very low exposure to sunlight, but if you combine that with lockdown, and now it's winter as well, it's really important to be thinking about vitamin D intake. And when we think about the environmental information for these patients, so At Great Ormond Street, we discharge children into stage on the home monitoring programme, which results in weekly calls from the specialist nurses. And we also have dietitians that keep care of all single ventricle patients looked after by Great Ormond Street Hospital. Not every centre will send patients home between the Norwood and the Glen, but at Great Ormond Street and at Southampton they do. Although this isn't possible for every patient, this is a programme which is there to support those patients who can go home. And they also have weekly, at Great Ormond Street, they all have weekly visits from the community nurses, and they check their SATs and their weight. So just quickly looking at neonatal hospital nutrition management. So this child was in hospital for the first 4 weeks of life. She had her Norwood at day 4. And prior to her Norwood, she actually wasn't fed. So as in line with GOSH guidelines, her weight was recorded at birth on the 9th centile. Height and length were, head circumference and length were not recorded. She actually arrived at Great Ormond Street on day 2. She was referred for PN on day 2 when she arrived at Great Ormond Street, started on day 3. We have a cut-off in the mornings for PN scripts, so she was referred after this cut-off. And she then had her Norwood on day 4, and she started PN after her Norwood again on day 5. This is when enough fluid was available. She also initiated the high-risk abdomen protocol, which I mentioned for babies at high risk of necrotizing enterocolitis. And for this, we used Express Human Milk. We really tried to support our mothers to express on CICU. At about 2 weeks old, she reached full enteral feeds and was weaned off TPN. When I say full enteral feeds, I mean to her fluid restriction, which at the time was 130 ml per kilo. We started a nutrient and energy dense whole protein formula and express breast milk alternate feeds. She had lost some weight, which is not surprising, all that she'd been through in the last 2 weeks. If babies are still building up to have their fluid requirement, often we do try and preserve them on exclusive breast milk, for as long as possible. But actually her demand was outstripping mum's supply at that stage. At 1 month old, she was discharged from Great Ormond Street. She was feeding on 150 ml per kilo, and that was alternate feeds of breast milk and nutrient dense formula. And she was having oral feeds with NG top-ups, and she had been seen by our speech therapist team here as well. She was discharged on Delphi Care Plan C with a weight on the 0.4 centile. So she had some catching up she'd need to be doing. So just from our neonatal management, because I imagine a lot of people watching this will be community dietitians, and they'll think, well, I don't see patients when they're in hospital after their Norwood, but it's just a few take-home messages. Growth faltering is really common in these children. They have lots of periods nilled by mouth for surgery and interventions, slow to build up feeds, and they're restricted on their fluid. Their energy requirements are often elevated as a result of need for catch-up growth, and that's not necessarily because of their cardiac lesion. They're often very well supported when they're discharged home with, here we do 2 weekly input in our single ventricle clinics, and their fluid allowance is liberal in comparison to other cardiac infants often. Then just talk about interstage nutrition management. So this is between the Norwood and the Glen, so much more likely for community or local dietitians to be seeing these infants. So she had 10 weeks between going home from Great Ormond Street and coming back for her Glen. During this time, she had quite a challenging time feeding, and she was parents' first baby. So it's really important to offer lots of support to these families. Parents did notice that her tolerance of high-calorie feeds was less good than express breast milk. So we combined them into a feed, so they were doing half the feed of breast milk and half the feed of high-calorie formula. But after a week of this at home, her reflux was worsening, and the GP prescribed Gaviscon. Now, it's really important to be thinking about constipation in these children, especially if they're prescribed Gaviscon, and for non-single ventricle patients who are much more fluid restricted as well. We also at that point changed to a hydrolyzed formula and gave parents advice around positional feeding. So this is something that we advised we'd given them before they went home, but it's worth kind of reiterating at this point about holding the syringe a bit lower so the feed can go in more slowly, keeping the baby upright, propping up their cot or their pram so that they're not lying too flat. At 7 weeks, she gained weight to the 2nd centile, so she'd gone up 1 weight centile since birth. And at 8 weeks, she was actually seen by the local speech therapist, who suggested that she could take more oral feeds, which was exciting for the family. But she was refusing the hydrolyzed feed. As she'd been doing quite well, we tried a whole protein feed again to see if she preferred the taste. And then at 9 weeks, she was having half feeds orally and remainder as NG top-up. So she was progressing well with her oral feeds at that point. She was getting really tired though, and as Luise mentioned earlier about fatigue and early satiety, she was definitely presenting with those kind of symptoms. At 11 weeks, she was taken to A&E because she was vomiting. Now, patients on the home monitoring program will have red flag indicators for when parents should seek urgent medical attention, and one of them is vomiting often, and it is this case for the GOSH home monitoring program, so she was taken to A&E. Other things that you might be wanting to look out for is increased sweatiness, breathlessness with feeding. A&E queried whether it was an infectious cause or worsening cardiac function, but it was felt that her cardiac function was worsening. She was switched back to a hydrolyzed feed because parents felt that she tolerated that a little bit better. She was given the breast milk by the bottle and then the hydrolyzed feed through the NG, and it was spaced between the two. So they paused feeds, winded her, and then started the NG feed afterwards. At that point, she was also, surgery was expedited at that point. So she then came in for surgery at 14 weeks. At that point, mum stopped expressing. I mean, I think she'd done a fantastic job to express for all of that time. But she just felt due to the stress of surgery and readmission. Her weight had actually got to the 2nd to the 9th percentile, and if you remember, she was born on the 9th, so that's brilliant. Her length was on the 25th to the 50th, so actually she gained length really nicely during this time. At 15 weeks, we changed her when she was going home post-Glen, so you'll see that Glen admission is often a lot more quick than the Norwood admission. She was discharged home on standard calorie infant formula. She was orally feeding completely. She had her tube out. Her weight was on the 9th centile, and her length was still 25th to 50th. So at that point, she was discharged from Dietetics. She'd achieved on weight and our feeding aims. And she now comes back to Great Ormond Street on a basis every couple of months for checkups and her single ventricle appointment. Just take-home messages. Tolerance of hydrolyzed feeds is often better than whole protein feeds, but this is not indicating a cow's milk protein allergy. This is to do with all of the symptoms that Luise discussed earlier around management of cardiac infants. Tolerance of feed should be considered in light of cardiac function. Interstage fluid management is critical for safety and must be directed by the medical team. And that's where close liaison with the medical team for your patients is really key. And often feeding improves post-op and fluid management can relax. This helps with the journey of weaning into complementary feeding. So this baby is a fantastic example of feeding improving. Not every baby does as amazingly as she did, but our hope is that things improve. And with that, I'd like to pass on to my colleague Amber, who's going to talk about the management of a baby with a ventricular septal defect. Thank you very much.
Hi, my name's Amber, and I'm also one of the cardiac and intensive care dietitians at Great Ormond Street Hospital. Today, I'm going to present a patient that has been particularly tricky to manage. He has a ventricular septal defect, and I've chosen this case study to illustrate some of the real difficulties we can have with these infants, and to reassure you all that sometimes the cardiac condition means that we just can't achieve the growth we want. So to give a bit of a background, a ventricular septal defect is basically a hole between the two ventricles. What happens then is you get high pressure blood from the left ventricle crossing to the right side of the heart, which then gets pumped to the lungs. The lungs aren't designed to have that high pressure pressure blood, so the gas exchange is impaired because of that. So you get a child that's working really hard with their breathing. They're very breathless. And they also get really easily tired. They don't finish full feeds just because they don't have the energy. But they're also burning more calories because they're breathing so quickly. Also, we know that in cardiac infants, because of the altered blood circulation to the gut, they have delayed gastric emptying, often have gastroesophageal reflux disease, often poor feed tolerance, commonly vomity babies that aren't as interested in feeds as a baby without a heart condition. So as a result, these septal defects particularly predispose these babies to wasting, and as a result of wasting, they get nutritional stunting with their height as well. So the background to my case study that I've chosen today, he was born at term. He did have an hypoplastic aortic arch and a large VSD. He was born on a good centile, 25th centile, and his length was 2nd to 9th. So the aortic arch repair was carried out on day 5 of life. However, the large VSD was left. That's usually repaired at an older age, once he'd grown, once he was a bigger weight. But as an interim measure, what happens is the surgeons put in place a PA band. So this is a band around the pulmonary artery, and this just limits the blood flow from the right ventricle to the lungs to try and reduce that high pressure blood going to the lungs and causing that work of breathing. So unfortunately, our little patient had a really rocky inpatient stay following their aortic arch repair. This, similar to the Norwood, has a high risk of necrotizing enterocolitis post-operatively, so they also go on our high-risk abdomen protocol, where we build up to feed very, very slowly. And our preference is to use breast milk until we get to a significant volume of feed, just because we know that reduces the risk of necrotizing enterocolitis and it does improve tolerance. So he was started on TPN to bridge the gap between reaching full enteral feeds and these very slow, gradual EBM feeds. He managed to reach 100 mils per kilo per day by day 6 post-op. However, at that point, he developed suspected necrotizing enterocolitis. Now, we like to be cautious with this, and that if there's any suspicion, then we treat them conservatively. They go nil by mouth for 5 days. They go on parenteral nutrition and triple antibiotics. Unfortunately, what this means is when that 5 days is finished, he went right back to the start of the high-risk enteral feeds again. And so it took him 3 weeks to get he was 3 weeks of age when he got back to 100 mils per kilo of EBM, and we know that's not meeting a normal infant's requirements. And at this stage, because of such a difficult hospital stay, he'd lost 13% from his birth weight, and that's at 3 weeks. He was 13% below his birth weight. He had dropped to the 2nd centile. So at this point, because he was on more than 100 mils per kilo per day feeds and tolerating them, we introduced a high-calorie formula to supplement the breast milk feeds to prevent any further deficit and hopefully to try and get some kind of catch-up if possible. However, he didn't tolerate this. As we said, cardiac babies, especially with this kind of heart defect, often are vomiting. He had large gastric aspirates. He was vomiting. He was uncomfortable on feeds. So we changed into a hydrolyzed high-calorie formula, which was tolerated a lot better. Mum, at that moment, decided to stop expressing. And so on the day of discharge, he was on full hydrolyzed high-calorie feeds to his fluid restriction at the time of 130 mils per kilo. And he was discharged on bottle feeds with NG gravity bolus top-ups. It took him until his 1-month birthday to get back to his birth weight. So obviously, at this point, he'd shown significant growth faltering. His weight was on the 0.4 centile and his length was on the 2nd centile. So his length centile had even slightly dropped because of the nutritional stunting in the first month of life due to how sick he was on our intensive care unit and cardiac ward. With the cardiologist agreement, we increased feeds to 140 mils per kilo per day of the hydrolyzed high-calorie formula, and this was still oral with NG top-ups. He was taking it all orally by the age of 2 months, but his weight gain remained really poor despite giving him such a vast amount of calories and protein. So our thought was that he was working too hard, and babies work harder on bottle feeds than NG feeds because they have to coordinate their suck swallow with breathing. So at this point, we suggested only half of the feed was given by bottle, half with the NG to reduce that work of breathing on bottle feeding. However, unfortunately, this little boy could not tolerate NG feeds. Even when the syringe was held lower, we gave all the advice. He would just projectile vomit after every NG feed. He took bottle feeds beautifully, tolerated them fine, no vomits, no positing, bowels opening regularly, plenty of wet nappies. So we continued with all bottle feeds on the 140 mils per kilo per day high calorie feeds, which meets the Delphi C guidelines, but he still did not gain weight. So at this point, we thought there's something not right here. He should be gaining weight on this, even with his high requirements, high increased work of breathing, he should be gaining weight. So we checked nutritional bloods. We requested urinary sodium measurement, and the cardiologist agreed to increase to 150 mils per kilo per day. The reason we requested nutritional bloods and sodium is sometimes, even with adequate energy and protein delivery, if there's a nutritional deficiency, this can impair growth. And we actually found with him, he was urinary sodium deficient, less than 20 millimoles per litre. Now, when they're on diuretics, this actually increases sodium loss in the urine. So if it's low in a cardiac infant on diuretics, you know it's definitely low. So the medical team agreed to start sodium chloride supplements. The feed was already exceeding the RNI, providing 2.24 millimoles per kilo per day. And the supplementary dose to start, if there's a deficiency, is recommended to be 1 to 2 millimoles per kilo per day. Unfortunately, this baby did not like the sodium at all. He was spitting it out. Mum had a real struggle getting it into him. And there was a further fall in his weight centile. At this point, 4 standard deviations below the 0.4 centile. You could have looked at that point and wondered what on earth the dietitians involved were doing. And at that point, he was sitting up. He was showing interest in food. He could support his head. He was reaching out to grab food. And at that point, we started high calorie weaning. He was only 4.5 months old. But often these cardiac babies that get very breathless on bottle feeds, poor tolerance of bottle feeds and formulas or milk, they can do well with food because it isn't so hard to, it doesn't cause such an increased work of breathing, and it's just another way to get nutrition into them. And so we started high calorie weaning fairly early. We recommended on using the high calorie formula in his morning breakfast, and then introducing smooth almond or peanut butter in both cooked main meals. We also talk about including protein foods and starchy carbohydrates fairly early on in that weaning process to make sure that that nutrition is getting into those weaning foods rather than just your pureed fruits and vegetables. However, despite Mum doing absolutely excellently getting all those calories into his food, he was eating food really well. He was doing so well with the portions, the variety. He was loving weaning, really doing well with food. We still didn't see catch-up weight gain, and it just doesn't make sense to us. He was on 120 calories per kilo from his formula at that stage, 3 good-sized meals a day, all fortified. He should have been catching up weight, and he was still barely clinging on to his weight centile. In the end, we discussed it with the cardiologist. He was having cardiac echoes, and that showed that the PA band that reduces the pulmonary blood flow to the lungs was too loose. So he was just working too hard. He was burning all the calories because the pressure in his lungs was too much, and he just needed surgery. So he had his PA band tightened. This is the really quite dreadful growth chart that we can see here. This doesn't include his weight since the PA band, but I'm glad to say that since his PA band, the last time I reviewed him, he'd actually gained just over 200 grams in 1 week, which easily exceeds any weight gain we have seen before. So I just wanted to show this case study to say sometimes we can do everything from a nutrition perspective we can possibly think of. And sometimes with a cardiac condition, we just really struggle until they have their surgery. Once he has his ventricular septal defect closure, we will aim for catch-up to within 1 centile of his birth weight. But sometimes it is unrealistic to expect that when they still have this unrepaired cardiac lesion. So in conclusion, from my case study, there were various strategies we used to optimise growth. First of all, a high-calorie hydrolyzed formula was chosen, not just for tolerance, but also for the energy and protein density in a child that is at risk of getting early satiety. We attempted to use an NG for half the feed to reduce the work of breathing. However, this wasn't tolerated, so it was not an ongoing practical option. Check for nutritional deficiencies, particularly things like zinc and selenium. And check sodium status if they're on diuretics. This may increase the losses of sodium so much so that they become deficient, and sodium is a known growth factor. If they're deficient in sodium, they will gain weight very poorly. We start high-calorie weaning when an infant is showing the signs they're ready, never before 4 months of age, 18 weeks, but if they're younger than 6 months, showing signs they could be ready, and we are struggling with growth, we will start that high-calorie weaning early. And we just need to make sure that protein is included. However, if we're really struggling, we need to involve the cardiologists. But sometimes, if we've tried every tool in our toolbox and they're not growing, this is a sign they need a cardiac intervention. Thank you ever so much for listening to me. Thank you to Luise, Brittany and Catherine for the very interesting talks before us. And I'm now going to pass back to Anna from Nutricia.
Thank you to Luise, Amber, Brittany and Catherine for that very interesting presentation. We will now move to the live panel discussion.
Thanks, Amber, Brittany and Catherine. Your talks were really interesting. We've had some really great questions. Manage dilated cardiomyopathy. So from our perspective, it depends on what the cause of the cardiomyopathy is. Sometimes, occasionally there's a nutrition cause such as vitamin D deficiency. So obviously we would treat that first, and then some of the principles that we would use for some of our other cardiac lesions would be similar. So if the child has had an acute weight loss, then we would promote catch-up growth through the use of either food fortification, depending on the age of the child, so nut butters, and regular small meals, and also an energy dense infant feed if the child is still little. Amber, from your perspective, what would you use? How would you manage a dilated cardiomyopathy?
Poor appetite, early satiety, and therefore not take enough to grow. So we just aim to provide them with sufficient calories and protein to support normal growth. And this could be through initially oral nutrition support, depending on the age, but sometimes it may necessitate nasogastric feeding if they have a really poor appetite. That means they just cannot meet their growth needs with high calorie foods and drinks.
Thanks so much, Amber. So we've got another question here that's really...
So our next... Oh, go for it, Louise.
So we've got, the next question is one that we often come across, and I think it's something that we commonly see, is about breast milk. So obviously, you know, we're all keen supporters of breast milk, and we want to ensure that all mothers who wish to breastfeed are able to. But because of the difficulty that many of these babies have in terms of fluid restriction and early satiety and difficulty in breastfeeding, it's not always possible. So what would be some of the things that you would do at Great Ormond Street?
So yeah, like Louise said, we do our absolute level best to support breastfeeding or use of express breast milk for as long or as much as possible. But sometimes the growth remains inadequate even when they are meeting their fluid restriction on exclusive breast milk. So at that point, many of you will have had a read through the Delphi guidelines and seen that was the suggestion of energy-dense formula uses a supplementation to breast milk. And we do use it as a supplementation, and I think it's important to note that the reason it says supplementation is because we're trying to support breastfeeding as much as possible rather than as a replacement too. There's also there are some babies that we'd use the preterm fortifier for, but only for preterm infants because that wouldn't meet the needs of the cardiac infant. Is that similar to you, Louise?
So that's been our experience. So I mean, I think ideally, if we had a breast milk fortifier that was similar to that was available for preterm infants, we would use that. But our experience of using the preterm breast milk fortifier in term infants is that often we end up with calcium and phosphate levels that are too high. And I think part of the difficulty is that once an infant has growth faltered down to the lowest centile, it becomes very difficult to catch them back up again, and they have to have sufficient energy in order to grow, and they then need extra energy on top of that in order to have catch-up weight gain, as Catherine was saying in her presentation. So really our experience now is, and using, having done an initial study of the Delphi guidelines, is that we are more able to support better growth if we intervene early, and that means in the first few weeks of life. And I think one of the things to remember is that poor nutritional status and poor weight gain is an independent risk factor for morbidity and mortality. So in some instances it just isn't possible to fully support breast milk, even though we would all wish to do so. So we've got some other really interesting questions. There was a question about Williams syndrome, Amber, and how we would manage those. I think you've got some really good experience of management of these types of children.
So I've had a couple of patients with Williams syndrome. So Williams syndrome is a syndrome that part of the syndrome is cardiovascular abnormalities, which is how they fall under cardiac. They don't all have high calcium levels. It's somewhere up to 50% of them might have hypercalcemia, and this is found by checking the bloods. So if they do have high calcium level, then we need to reduce the dietary calcium. Now, this is commonly a problem in infancy in Williams, and usually is outgrown by the age of 2 to 4 years. And it's monitored with regular calcium checks 2 to 4 times a year. So we have a formula that's low in calcium called Locosol, and it may be that all feeds need to be replaced with that initially to bring that serum calcium down into reference range, or it might be that it can be given alongside breastfeeds or normal formula feeds, depending on what they're on, and then monitor that calcium level. If they're slightly older, say weaning babies or young toddlers, then they would need to avoid foods that are rich in vitamin D and calcium, and they may also be carrying on the Locosol as a supplementary drink to low calcium, low vitamin D foods. But there's actually a really good section in the manual written by my renal colleague Luise. So if you are interested in Williams, I would highly recommend reading that section in the paediatric manual.
Amber. And Brittany, there's a great question here about the use of energy-dense formulas, whether we would encourage supplementing with an energy-dense formula with EBM before growth faltering, and I just wondered what your experience of that was.
Yeah, sure. Thanks, Louise. So, of course, we try to support families as much as possible. Like Louise said as well, at GOSH, we try to support families with exclusive breastfeeding. But of course, sometimes we do need to have the discussion with parents before all of this does happen. And we prefer to have that conversation up front with parents just to give them what the pros and cons might be of using certain formulas down the line. But we do find it easier if we inform parents about all the kind of things that they might expect down the line in case we do need to use a high-calorie formula. And of course, we would only need to use a high-calorie formula if we can't achieve what we need to with breast milk, or if there's some sort of reason why we aren't achieving growth, or there is some sort of growth faltering. But we do obviously prefer to have that talk with parents before they start their journey, as a sort of a pre-surgical nutrition talk, if you will, just to give them an idea of what to expect, and so that later down the line, if we do need to sort of have this conversation with them, that we can then, you know, meet their expectations, and sort of they can have questions in their mind about what they would like from us and what we need to achieve with them, basically.
So the next question that's come in says, good evening from Moscow. It's lovely to hear where everyone's tuning in from. Do you use donor breast milk in feeding infants after cardiac surgery? So I think if Luise, if you want to give the Southampton view, and I can tell you what we do here at GAR.
Yes, so thank you, and it's a great question. So for some of our infants who are following the high-risk protocol that we have, and or who have a recent experience of suspected NEC, then we would use donor breast milk, and or we use an extensively hydrolyzed energy-dense infant formula. So if parents don't wish to have donor breast milk, then we would use, and we don't have access to breast milk, we would use an extensively hydrolyzed nutrient energy dense formula, which we use at full strength from day one. So yes, we use donor breast milk.
Thank you. From Great Ormond Street, so we've never actually, so we have 3 different intensive cares, 4 at the moment because we have an extra COVID one. We have the neonatal one, general paediatric, and cardiac. Neonatal unit have been using donor breast milk for some time. The cardiac unit are just starting, which is very exciting. So for our children on the high risk abdomen protocols, that's high risk of necrotizing enterocolitis, we would use breast milk as their first line, a donor breast milk as their second line, and then we use a hydrolyzed formula as the third line. So very similar to what Southampton do, but we're just in the early days of it, so it's an exciting new project.
We've had a few questions about the use of extensively hydrolyzed infant formulas in cardiac infants, and I think it is a common thing that we see that infants need to have, and one of the questions relates to cardiac babies without cow's milk protein allergy. So one of the reasons, so we have got some evidence for the use of extensively hydrolyzed nutrient dense energy feeds, and that's certainly in our Paediatric intensive care. We've published a small case review between 2 centres, so we looked at 44 infants altogether and found, given that certainly in following cardiac surgery, we're more able to meet their energy requirements. Our experience also is if the infants are not tolerating a whole protein feed because they've got delayed gastric emptying and because they've got such severe gastroesophageal reflux, sometimes they tolerate an extensively hydrolyzed feed better because it empties from their stomach quicker. So certainly if they're not tolerating a whole protein nutrient energy dense feed and or breast milk in combination, we may sometimes give them an extensively hydrolyzed feed that's the nutrient energy dense one, as to see whether they will tolerate that better. So sort of Amber and Catherine and Brittany, from your perspective, what would your experience at GOS be?
Yeah, so the same as you, we know that they have delayed gastric emptying, and a feed that's whether that's partially hydrolyzed or extensively hydrolyzed has faster gastric transit. So that means that it's not sitting in their stomach for as long. They're not as refluxy and vomity. So certainly that's our experience, that we use a lot of hydrolyzed feeds in our cardiac babies for the same reasons. Yeah, and I agree with Amber. I mean, we work together, so that's probably why. But I would also say that there are a lot of cardiac infants that we see with there's a high rate of diagnosis of cow's milk protein allergy in these children, and the use of if a child tolerates a hydrolyzed formula better, and that doesn't necessarily mean they have an allergy. So I think we do sometimes see a sort of over-diagnosis of cow's milk protein allergy in these infants, and quite often after surgery their feeding tolerance will improve massively. and often they go home on a whole protein formula when they came in on something else. So it's just worth considering, I think, if you see vomiting and reflux in isolation, or other symptoms that could be explained by their heart function, then that could be a reason for their feeding tolerance issues. Question here, which is an interesting one. Do you find that babies who are fully enteral fed grow better than those who are fully bottle fed, or a combination of bottle and enteral feeding? I don't know who wants to answer that. Brittany, do you want to comment on that maybe?
I mean, I know from just our team, we obviously try as much as possible with our oral feeders as much as we can, but of course when we get to a stage where infants are becoming breathless or not managing the volumes that they need to manage in order to sort of sustain their growth, we will obviously advise on if we can use tube feeds. Of course, we'll try to support as much as possible and manage the fluid restriction. But yeah, I mean, I don't know if there's some studies available at the moment to say which one might be better, but of course, you know, it depends patient to patient, as you saw from Amber's case study. If those are infants that are struggling on oral feeds and not finishing volumes, and becoming sort of, like I said, breathless and sweaty and losing weight at the same time, then of course we would advise to go for tube feeding in order to help the patient. And it's merely just, you know, something that's beneficial to them rather than a hindrance. And of course, you know, there's been a lot of questions with regards to what can be done in the community, or maybe where nursing teams can help as well. And that's something that we work so closely with our cardiac nurse specialists, which also phone weekly, and they check in with us with regards to the fluid restrictions, and we with them, and they also manage the symptoms as well and check if cardiac infants need further help with tube feeds. So we're always well supported with our team as well, and that's something that I'm sure all centres could consider, working closely with their cardiac nurse specialists and the community nursing teams as well.
And I think just to finish off, maybe one of the last things to say is that it's really important with all of these babies to try and keep some oral feeds going. And I think that's, you know, the point about NG feeding. So yes, many of these babies do require nasogastric tubes because they get so tired so quickly. But where possible, it's always really important, and where safe, is to provide a little bit of oral feed at the same time that they're being NG fed, and for babies to be picked up and held rather than to be lying down, so that there's some still nurturing and that usual touch that we would normally have for babies who didn't have an NG tube. So I think all of the questions have been answered for this evening, and we're going to hand back to Anna to conclude. But thank you very much for all of the very interesting questions, and thank you for listening.
I would like to thank Louise, Amber, Brittany and Catherine for speaking this evening, and to everyone for attending.